Conrad Fisher with our next section in endocrinology. The posterior pituitary is a short section, suffers from some difficult terminology of anti-diuretic hormone, and other than that, it's actually got one simple function. I am dry. How do I increase my level of water? The posterior pituitary is different than anterior in the sense that in the posterior pituitary, the hormones are not made at all in the posterior pituitary. They're made exclusively in the neural tissue of the hypothalamus. They're exclusively stored in the posterior. Therefore, damage to the posterior pituitary does not lose all the hormones, it just temporarily loses the storage. It's kind of like if you destroy all the bookstores, you get rid of Borders, you still can get books. Why? Because we buy them directly from Amazon in your hypothalamus. That's why it is that when you lose the anterior pituitary and squish that, you don't get those hormones ever because they're made only in the anterior pituitary. In the posterior pituitary, they're made in the hypothalamus and only stored in the posterior pituitary. The hormones there are ADH and oxytocin. Now, this is going to suffer from some terminology. How come we're calling it arginine vasopressin, then antidiuretic hormone, then sometimes we also call it desmopressin, then DDAVP for D-dearginine vasopressin? Well, because it's really all the same substance. It's just a matter of the amount. For instance, ADH at low levels increases the absorption of water at the collecting duct. But when it goes to higher amounts, it's a vasoconstrictor, called vasopressin. Well, is there something different in the chemical? No, it's just the amount. And oxytocin is in the posterior pituitary, and in a man, you don't notice it your whole life. In a woman, it helps her at parturition and also helps in breastfeeding. However, you can still deliver and breastfeed without it. So oxytocin has no deficiency disease and no excess disease. The cell bodies are in the supraoptic and paraventricular nuclei where these substances are made. Now, it is for us on step one a big deal that you know the difference between the term where are they made versus where do they have their storage. So they are made in the hypothalamus and stored in the posterior pituitary. Arginine vasopressin and antidiuretic hormone are the same substance. They control water excretion, extracellular fluid volume, osmolality. Look, I just said the same thing in 3 different ways. If you increase water excretion, your fluid volumes go down and your osmolalities go up. So volumes and osmolality are always in the opposite direction, aren't they? Yes, they are. The hypothalamic osmoreceptors maintains the extracellular fluid volume, osmolality. How narrow a range? 1%. Which one do you sense more easily? Osmolality or volume? You sense osmolality more easily. We sense a 1% change in our osmolality, but we need a 10% change in our volume. It's a 1% change in osmolality, but a 10% change in our volume. Oh, that's a huge difference, isn't it now? Yes, it is. 1% change in volume, 10% change, in volume, 1% change in osmolality. So where are the osmoreceptors? They're in the hypothalamus. Where are the volume and pressure receptors? They're in our carotids, in our atria. Volume receptors, sense 10%. And we reset the osmoreceptor downward. What does that mean is that if you have a person who's not pregnant, they will shut off ADH at an osmolality of 280 or so. But a person who's pregnant continues to make ADH, even when the osmolality hits 280. And that's why a pregnant lady will continue to absorb more water than a non-pregnant lady. Now, cortisol and thyroid hormone also have an effect on this, and that is why people who have thyroid and cortisol problems also have differences in free water clearance. This is part of the reason that people seem to gain weight when people have hypothyroidism and Cushing's disease. It changes the amount of free water. The volume or stretch receptors, the mechanoreceptors that detect volume in the body, are in the atria and in the carotid sinus. So when you see a decrease in volume, it results in less firing. Afferent means from the receptor to the central nervous system, to the medulla. Afferent. I always was wondering, what does it mean, afferent to? Well, everything's sort of to something. Yeah, but afferent for us means to the central nervous system. When you don't fire those mechanoreceptors, there's less volume, so the mechanoreceptors don't fire. When they don't fire, that's decreased afferent activity to the medulla, and that results in increase in our ADH. Now, when you have an increase in your volume, more stretch, they're mechanoreceptors, increase afferent activity. And you have to know that it's on cranial nerves 9 and 10. 9 in the carotid, 10 in the heart. 9 in the carotid, 10 in the heart. Glossopharyngeal. 9 in the carotid, 10 in the heart. 9 in the carotid, 10 in the heart. The osmoreceptors. By the way, they enter where? Here's a neuroanatomy correlation. What nerve do they go in with? The nucleus solitarius tract with cranial nerve 7. The nucleus solitarius tract with cranial nerve 7. And the osmoreceptors are in the hypothalamus, sensing a 1% change in osmolality. The paraventricular and supraoptic nuclei make the ADH, and it's stored in the posterior. And the final, in the lower right-hand corner, you'll see that the osmolality of the urine ranges from 300 to 1200 based on the normal bodily osmolality is around 300. We're going to round it off and goes to a maximum of 1200. See, one of the things that's interesting about this is that at the kidney, if you absorb all this water, how come the osmolality doesn't dilute out there? Because you're bringing urea in with it. Did you know that there is a urea transporter that gets stimulated by ADH in the collecting duct? The urea transporter that gets stimulated by ADH? What's the name of the urea transporter? It's called urea transporter. What's the soup du jour? It's the soup of the day. The target of antidiuretic hormone is in the V2 receptor, in the collecting duct, in the tubules. How do you know that the V2 receptor is in the tubules? Maybe it's the V1. Why is the V2 in the V-tubules? Oh yes, V-tubule. V2 are in the tubules. Yes, V1 is in blood vessels. V2 water, V1 blood pressure. And what great name is this? Increases ductal permeability to water by putting aquaporins. Water pores. Let me ask you, does the water pour out or does the water pour in? The water pours in. That's why it's called aquaporin, because the water pours in. Well, what do we mean by pour in? We mean into the tubule or into the body? When the aquaporins are put in place, the water comes into the body, back into the interstitium of the medulla. It doesn't leave the body and go into the tubules. It leaves the tubule coming back into the body. And we say water is passively absorbed because there's no ATP being split. Now, step one is very big on you knowing where ATP is split. For instance, water reabsorption is passive there based on osmolality. When we say absorbed according to an osmolar gradient, that's passive because there's no ATP. Osmolar gradients from our point of view are passive. Is filtration at the glomerulus active or passive? Filtration is passive because there's no ATP being split. So from our point of view, active transport means that it uses ATP. This is passive. The urea passes with water, but the electrolytes cannot. This is a very big deal. ADH is purely a water hormone. And the urea passes with water because ADH stimulates urea absorption with the urea transporter. ADH stimulates it so that we don't dilute out the interstitium of the renal medulla. Now, in severe hemorrhage, ADH acts on a V1 receptor, and V1 is for blood pressure. So that's why it is that V1 is vasoconstrictor. It increases the blood pressure. V2 is the tubulin water. V1 is for blood pressure. Vasoconstrictor. Vasopressin is a vasoconstrictor. The volume regulation, which is stretch receptors, and they can chronically inhibit some ADH secretion. For instance, decreased blood pressure can cause venous and arterial stretch receptors to send fewer signals to the CNS and can decrease ADH. Oh, that's very interesting, and therefore it is a mechanism for restoring volume after a hemorrhage. So there's a different way of saying the same thing I said before, but it's just saying that volume goes up because there's vasopressin causing vasoconstriction and ADH causing water absorption. Osmoreceptors sense a 1% change in the hypothalamus to increase that ADH secretion, and the same amount of change in the opposite direction shuts off ADH. So the point here is for you to understand that it's both a 1% change in dryness increases the ADH, and a 1% increase in the wetness decreases the ADH. So 1% up or down changes our osmolality, and therefore it can change ADH a lot. It's amazing, isn't it, how finely tuned it's set? So it keeps the osmostat, keeps the extracellular fluid osmolality around 285. Don't be disturbed if you see it rounded to 300, because it's close enough for us to be able to answer the questions. This also explains why it is that when you are drinking water, you don't need a 10% change in your volume to take a sip of water. You not only sense the dryness in your mouth, but even a tiny change of 1% in osmolality will stimulate you to drink water. And that's why it is that you don't have to wait until you actually get hypotensive to drink fluids. And that's the mechanism of why we don't become hypotensive, because our osmostat changes way before our blood pressure would change. Our osmostat changes way before we'd sense a change in blood pressure. In long-term spaceflight, in a weightless environment, the biggest damage is that you have a resorption of bone. So if you're up in a space station for 6 months, you'll end up coming out with bones that are like chicken bones. Now the other part about it is weightless environments also suppress ADH, because in a weightless environment there's a shift of blood from the limbs into the chest. So when you get the extra volume in your chest, the stretch receptors stretch more in your atria and carotids and send a signal to your posterior pituitary and to your hypothalamus to shut off both the formation and the release of antidiuretic hormones, because it stretches those volume receptors in the veins and the atria. Now, the other thing about alcohol, ethyl alcohol, is why do you get a hangover when you drink a lot, if you drink a lot? And that's because ADH is inhibited by alcohol. That's why it is that when you drink 12 ounces of beer, you'll probably urinate out 13 or 14 ounces. And when you urinate out more volume than you took in, that eventually has an effect on the cerebrospinal fluid. When you lose cerebrospinal fluid, it ends up causing a headache. And that is the mechanism of the hangover. See, there's all these great benefits for you of learning step 1, is you now know the mechanism of hangovers. That is, ethyl alcohol causes you to have a type of diabetes insipidus. Alcohol causes diabetes insipidus. Hence, you don't really buy the beer, you just rent it. Atrial natriuretic peptide is named in the time of the modern thing of naming hormones according to what they do, not somebody's name. So therefore, atrial natriuretic peptide is a great name because it tells you that you sense stretch in the atria and then you lose sodium and water. Natrium is the old Greek word for sodium. So you urinate out natrium or sodium. So when you sense a stretch in the atria, atrial natriuretic peptide goes up and you urinate out both salt and water. Now, the stimuli releasing ANP are stretch of the atria as well as increased salt intake. or CHF. Now this is why it is that when you have hyperaldosteronism, why don't we have a high serum sodium with high aldosterone? You're absorbing all that sodium. How come you don't have hypernatremia? Well, atrial natriuretic peptide takes the sodium and the volume it senses and makes you urinate it out. Also, when you have SIADH and you absorb all that water, why do you have a high sodium in your urine? And one of the reasons is atrial natriuretic peptide. Now, ANP therapeutically is not so good. There's a drug called nasiritide, which we don't use too much. It's synthetic atrial natriuretic peptide, not too useful. But we use ANP levels as a diagnostic test in congestive heart failure. So as a diagnostic test in CHF, a normal BNP or atrial natriuretic peptide level excludes congestive failure. Now, an elevated ANP doesn't mean you have congestive failure, but a normal ANP excludes congestive heart failure because we know that any cause of a stretch of the heart, whether it's a pulmonary embolus, dilated cardiomyopathy, congestive heart failure, anything, will increase ANP. So it's terribly nonspecific. But a normal ANP means no congestive failure. Now, atrial natriuretic peptide is a hormone that has no deficiency state known and no excess disease. And that's one of the things that we're going to do in the endocrine physiology section. We're going to say, here's the normal function of this hormone. What is the deficiency disease? What is the excess disease? And how do we use it therapeutically? Here's the normal function. What's the deficiency disease? What's the excess disease? And how do we use it therapeutically? What's the normal function of ANP? It senses the stretch in the atria, urinate out salt and water. What's the deficiency disease called? There isn't any. What's the excess disease called? There isn't any. Atrial natriuretic peptide makes you urinate out salt and water and also increases glomerular filtration rate and makes you urinate out both of those. And so there is a dilation of the afferent arteriole, which increases glomerular filtration rate, and a constriction of the efferent arteriole. Isn't that fantastic? This is showing you early on exactly how it is that we form urine. Natriuresis and diuresis inhibits aldosterone release, and it also inhibits the reabsorption of sodium and water in the collecting duct, so you urinate out both. Atrial natriuretic peptide inhibits the effect of angiotensin II in ADH. Now, it's the same effect that happens at the efferent arteriole, but it has a different effect at the blood vessels. So a normal ANP excludes congestive failure. Elevated atrial natriuretic peptide is very nonspecific. However, a normal atrial natriuretic peptide excludes congestive failure. Diabetes insipidus means insufficiency of ADH. It either is an insufficiency of the amount of ADH or an insufficiency in the effect of ADH. The word diabetes itself directly means a fountain. Why? Because you're urinating all the time. A fountain. And insipid means bland or tasteless, whereas mellitus, where we get the word mellifluous, means sweet. That's why diabetes mellitus means a sweet fountain. Diabetes insipidus means a bland fountain. So the ancient Greeks may have been awfully good on astronomy, but in terms of their medicine, all they could describe was the taste of urine, apparently. So central diabetes insipidus is ADH deficiency, and this happens from tumor, trauma, hypoxia, anything that damages the posterior pituitary or the hypothalamus. Tumor, trauma, autoimmune, inflammatory things, anything that results in damage to the posterior pituitary or to the hypothalamus in general can cause diabetes insipidus. And you'll know it's central diabetes insipidus because when you give ADH, there'll be both a decrease in the urine volume and an increase in the urine osmolality. When you give ADH, there's both a decrease in the urine volume and an increase in the urine osmolarity. Decrease in the urine volume, increase in the osmolality. Decrease in the urine volume, increase in urine osmolarity in response to giving vasopressin. And the management of central diabetes insipidus or ADH deficiency is just give them some ADH. That's it. And you treat by giving ADH lifelong if need be. However, many people have a transient central diabetes insipidus from damage to the posterior pituitary, and then the hypothalamus takes over after a while. For instance, a guy has a car accident, his posterior pituitary is destroyed, there is a transient decrease in the level of ADH, and then it takes over that in about 2 days, the hypothalamus will just start shipping directly. And you could be on ADH the rest of your life in ADH replacement. It's not that big a deal. Nephrogenic diabetes insipidus is much more difficult because, first of all, if you can't correct the underlying cause, nephrogenic diabetes insipidus can be quite difficult to manage. The two biggest causes that we know of are low potassium. You need a normal potassium for ADH to work at the kidney, and high calcium. High calcium is very damaging, and that is why it is that people with hypercalcemia have massive volume deficits. People with hypercalcemia have a massive volume deficit because they're having a nephrogenic diabetes insipidus. The ADH does not take an effect on the kidney. It's usually in people who have both not only potassium and calcium problems, but other people who have damaged kidneys on a long-term basis. Now, if you can't fix the underlying cause, you're stuck with giving a diuretic to try and change the concentrating ability. And that's very difficult, isn't it? Using a diuretic in someone urinating 20 liters a day? Oy. This table looks at how to diagnose diabetes insipidus and the etiology of it. So a normal person, the average plasma osmolality is about 300. I know we're saying 297 here, but that's because that's very precise. It's very close to 300. Now, urine osmolality, when you do water deprivation, should go up. The urine osmolality should go up because you should be concentrating your urine. Now, theoretically, it could go even higher than that. But the point is, in diabetes insipidus from both central and nephrogenic, you notice that the urine osmolality is quite low because you can't concentrate the urine. Now, in a central diabetes insipidus, the plasma ADH level is down because you're not making the ADH because of damage to the hypothalamus of the posterior pituitary. Once we give you exogenous desmopressin, the central diabetes insipidus, the urine osmolality will shoot up. But in nephrogenic diabetes insipidus, it will go nowhere because you have no ability to be able to raise the osmolality from giving ADH because the kidney is simply not working. Now, that's the bottom line about the diagnosis. In central diabetes insipidus, you give ADH and the osmolality goes up. In nephrogenic, you give ADH and the osmolality goes nowhere. And going from 106 to 118 in nephrogenic is not a significant difference. It would have to be much greater than that. In central diabetes insipidus, ADH works. In nephrogenic diabetes insipidus, ADH does not work when given exogenously. The opposite of diabetes insipidus with insufficient ADH release, insufficient ADH production in central, or insufficient ADH effect in nephrogenic, the opposite of diabetes insipidus is SIDH. Too much ADH. And SIDH means that you're abnormally reabsorbing water in the collecting duct and abnormally dropping your serum sodium. Anything in the brain can do it, so it's better, instead of going through and saying stroke, tumor, trauma, hypoxia, brain hemorrhage, it's better just say any brain problem can do it. Now, why does lung pathology do it? It's not just small cell lung cancer. And we make people memorize that. But it's not just small cell cancer. It's small cell, large cell, pneumonia, tuberculosis, atelectasis, pulmonary embolus. Anything in the lung, anything in the brain can cause SIDH. We don't know why. Why does pneumonia cause SIDH? I don't know why. Why do you get ADH out of a pneumonia? Not clear. Any lung, any brain, drugs like carbamazepine, the seizure medication, carbamazepine, or SSRIs, or even pain. Did you know that pain can cause SIDH? Just pain? Yeah, just pain causes SIDH. Why? Any lung, any brain, drugs, and cancer. Any lung, any brain, drugs, and cancer. Anything in the lung, anything in the brain, drugs, and cancer can all cause SIDH. Inappropriate concentration of urine when the blood or plasma sodium is low. you're still absorbing too much free water. SIDH gives you increased water retention, but you don't get an excess volume overload. It's very interesting for people, isn't it? If I'm retaining all this water, how come I don't get edema? One of the reasons for this is that the volume expansion increases atrial natriuretic peptide. And this ANP ends up making you urinate out water and sodium, but mostly the sodium, because the volume expansion makes you, that's why part of the reason you have an high urine sodium. You see, SIDH is diagnosed by saying, I have a urine sodium that's high when my blood sodium is low. That's inappropriate. My urine sodium is high when my blood sodium is low. My urine sodium is high when my blood sodium is low. That's SIDH. And that's also why you don't get volume expansion. You do get an inappropriate concentration of the urine, and that means both urine sodium and urine osmolality are inappropriately high. When you have a low plasma sodium, why are you urinating out sodium and osmolality? You don't have osmoles. Why are you urinating it out? That's inappropriate. You don't have osmoles in SIDH. You have a low plasma sodium. Why are you urinating them out? It's inappropriate. See, if you have hyponatremia, anybody with a urine osmolality that's above maximum dilution, anybody with a urine osmolality above maximum dilution is 50 or 100. And if it's anything above that, it's inappropriate. The initial management of SIDH is fluid restriction. Now, we don't do salt restriction because we don't have salt in our blood. So we don't want to do salt restriction because we want salt in there. Fluid restriction, it will manage itself. But if a person has any severe symptoms, you can't just do fluid restriction. You have to give either hypertonic saline or one of the ADH blockers, one of the Vaptans, conivaptan and tolvaptan. Mild hyponatremia can be managed with fluid restriction. More severe disease needs either hypertonic saline or V2 receptor antagonist, conivaptan, tolvaptan. Conivaptan and tolvaptan do what you used to do with dimeclocycline. Dimeclocycline is largely replaced with conivaptan and tolvaptan. And conivaptan and tolvaptan are not new drugs. They've been around for over a decade. They are, however, often new to Step 1 students because you have to accept the fact that we tend to be very out of date on the pharmacology end in Step 1. So the reason why hypertonic saline is difficult is that if you correct the sodium up too fast, it causes its own independent problems. What happens when you correct the sodium up too fast? You get central pontine myelinolysis. You melt your own pons by bringing it up too fast. So hypertonic saline or V2 receptor antagonist, but don't come up too fast. Well, isn't this a large and annoying table? Believe it or not, it actually says what I said before. First of all, you've got to go through each one of these so you demystify this. The first thing is about permeability. Because permeability, from the point of view of ADH, mean water leaving the body or entering. Leaving the body means it's going from the kidney interstitium into the collecting ducts. Entering the body means it's leaving the collecting duct and coming back into the body and into the interstitium. So permeability means retaining water. Now, every time you have a low ADH, you have decreased permeability. And that's in both diabetes insipidus and primary polydipsia. Primary polydipsia is sometimes called psychogenic polydipsia. Well, if you have decreased permeability, you must have an increased urine flow. So lines 1 and 2 you see will always go the opposite of each other. If its permeability is up, the urine flow is down. And if the flow is up, the osmolality has to be down. Because if you can show me somebody who's got a high urine flow and also increases their urine osmolality, you should publish that in the Bible, because it would be a miracle. So if you have a urine flow that's up, urine osmolality has to go down. And if you have urine flow that's down, urine osmolality has to go up. They always go in the opposite direction. Now, excreting urine also means that the volumes in the body, and here it is, I would just put, you'll also see that every time the extracellular fluid volume is down, the intracellular fluid volume is down. Every time the extracellular fluid volume is up, the intracellular fluid volume is up. So for us, we're not going to separate these out. We should just put them together. ECF and ICF volume, ECF and ICF osmolality. Now, every time you have increased urine flow, the volumes in the extracellular fluids and intracellular fluids goes down, and the osmolalities go up, because they're in the opposite direction. So let's summarize hyponatremia. It's usually the same thing as saying hypoosmolar, because the vast majority of osmolality is sodium. Matter of fact, 2 times the sodium plus 10. If you have normal glucose and normal urea, it's 2 times the sodium plus 10. Technically, serum osmolality is 2 times the sodium plus the glucose over 18, and the BUN, blood urea nitrogen, divided by 2.8. So in a normal person, if the glucose and the urea are normal, they only amount to 8 or 10 points. So in a normal person, the serum osmolality is 2 times the sodium plus 10. So hyponatremia and hypoosmolar are pretty much the same thing. And what ends up happening is that in both loss of solutes is the sodium, and too much water. In severe hyponatremia, you get a seizure. Low sodium suddenly is a seizure. CNS. Low sodium, seizures, CNS. High sodium, seizures, CNS. Now, whether you go high sodium, it's a seizures, it's CNS, and a low sodium is a seizures and CNS, sodium CNS. Can you get an arrhythmia from sodium disorders? No. You don't get arrhythmias from sodium disorders. You get arrhythmias from potassium problems. Hyperkalemia is cardiac. Hypokalemia is cardiac. So kalemic is cardiac, and a sodium is a CNS. She sells sodium by the seizures, sure. The other thing is the rate at which these occur. If the changes in sodium happen suddenly, you will seize and be confused right away. If the changes in sodium happen slowly or gradually, you won't feel anything for a long time to come. In other words, a person who suddenly goes to a sodium of 120 will have a seizure. But if I brought you down 1 or 2 points today and 1 or 2 points tomorrow and 1 or 2 points, and remember, normal sodium is 140, if I brought your sodium down slowly, a point or 2 a day, you can go down to a sodium of 110 and not feel it. But if I bring your sodium down very quickly, you'll have a seizure. Chronic hyponatremia developing slowly will leave the person asymptomatic. You will not have symptoms if it happens slowly. An awful lot of the symptoms of sodium disorders is directly related to how quickly it occurs. A person whose sodium takes a long time to get down there can tolerate profoundly low sodiums. If you aggressively treat it, meaning you raise that sodium up more than a point an hour, you will melt that pons. People develop visual disturbance because the cranial nerve nuclei go right through the pons. You'll get diplopia, dysphagia, dysarthria, because it'll melt your pons. And bring the sodium up over a few days. Don't be in a hurry. Now, there is a hypervolemic hyponatremia, not too often, can be sometimes, and it's really not saying a high intravascular volume, but rather peripheral volume, like edema. So this is very confusing for people. How can you have hypervolemic but have hyponatremia? Because it's hypervolemic for the whole body, not for the blood vessels. If the blood vessels had a high volume, you'd have hyponatremia, but this is hypervolemic inside the tissues. And what ends up happening, it's kind of an appropriate increase in ADH. See, if you have a heart that doesn't beat and you don't perfuse things, the body says we've got to retain water to maintain perfusion pressure. You go, well, we can retain water to maintain perfusion pressure, but the end result is, though, unless you can fix the sodium problem, that the person sacrifices sodium levels to maintain perfusion pressure, because perfusion pressure is more important than the sodium level. Hypovolemic is when people just have loss of sodium out of their urine. Usually when you have no aldosterone, you lose salt and water, salt and water. Diuretics, you lose salt and water. Diarrhea, you're losing salt and water. It's just saying loss of salt and water together. And finally, the only meaningful euvolemic, and eu is where we get the word euthanasia, euphemism, euphoria, for good, true, or normal. Euvolemic means good, true, or normal volume status, and the most common cause of that is SIADH. Well, if it isn't a beautiful shot of our anterior and posterior pituitary, you could tell me this is anything. You could tell me it was an ovary for all I know. You could tell me this is like a thyroid. I don't know what that is, but that's what we're telling you it is. Must be true. We said it.